second lecture this semester and the last one. Yeah, thanks God. I know you don't like that, so it's just a last one. Okay, that lecture is dedicated to sialoadenitis, sialolithiasis, and sialosis. And of course, we have to talk about arthritis and arthrosis of the temporomandibular joint. You could see that abbreviation TMJ, so you know what is that. Okay, as you remember, right? As you remember, we have a few salivary glands. We have three pair, okay? And I don't know if there's a point to repeat all that things, but okay. So we have a submandibular, parotid gland, and sublingual, and of course we have over 600, and in other books and sources, they said about one thousand, but it not possible to um, how to say calculate all that glands. So it's few hundreds, let's say like this. So a few hundred minor salivary glands that really are very useful in our mouth because they produce about 10% of total salivary volume, as you can see here. The the lower one picture, and I suppose it's from Anatomic Atlas of Nectar. Very looks like this. Yeah, it's nectar. Okay, so you can see where there accumulates more. So it's a palatine region or area, okay? And the retromolar region. So be careful when you remove the wisdom tooth. Of course, you cannot see those minor salivary glands, but still be careful with soft tissues when you remove the third molars. Okay, so distribute over lips, cheeks, palate, floor of the mouth, and retromolar. Yeah, I said that. Okay. I have to say that again, guys, I don't have any time to repeat all that things. So I just see that information from the beginning, not rewatched it. Okay, so we have as we have. Okay, so sublingual salivary glands. It's the smallest one. Yep. So of the major salivary glands, the smallest of three pair, as you remember. The almond-shaped gland lies just deep to the floor of the mouth mucus between the mandible and hemiglossus muscle. Not sure, really, I'm not sure how to pronounce all those words, I mean, that came from Latin. So maybe my pronunciation could be Latini, because I'm not sure how to pronounce correctly in English, genioglossus muscle. So in Latin, it's genioglossus. Okay. It is bounded inferiorly by the, again, I don't know how to pronounce that, mylohyoid perhaps, yeah? But still, you remember the Latin, you remember the anatomy, so you know what is that. And sublingual gland has two true fascial capsule. It's very important information. When you're removing the salivary glands, you have to remove the capsule too. And if some of the parts of the gland you left it, that could be huge problems because those salivatory glands tissues, I mean mucous tissues, they uh, contain to produce the secret, and there is no duct, okay? Duct, you know? You understand what is that, right? So it's like tube, which gland used to evacuate the secret. Whew, I hope you understand me. Okay. It lacks a single dominant, oh yeah, duct, okay? Instead, it is drained by approximately 10 small ducts. Okay. Submandibular gland. This gland lies in the submandibular triangle formed by the anterior and posterior obelisks of the not sure how to pronounce that. It's musculus digastricus, okay? Digastric, maybe, not sure. If you know, tell me. Really, I'm gonna be thankful for that.
We say gastric, so it's gonna be digastric.
Digastric. Yeah, okay, let it be digastric muscle. So musculus digastricus, or also the same muscle is musculus biventer. It's the same, both name are for one muscle. You can say like this, you can say like this. Okay. The gland form a C around the anterior margin of the mylohyoid, I suppose, muscle, which divides the gland into a superficial and deep lobe. Again, once again, I know that you will not do that in your country as a dentist chirurgien, but we have to follow the program, the plan of program. So we talk about that because here we have a stomatologist, and stomatologist take care of the salivatory glands too, and of temporomandibular joint as well. That's why it's stomatologist, not dentist. But still, we need to repeat that. You already know from the first and second year anatomy things. Okay. I have to say that all those three salivatory gland, the big salivatory gland, they have their own duct, and each of those ducts they have a proper name of first doctor or scientist who discovered that. So if we talk about submandibular gland, that duct calls Wharton duct. Not sure that you have to remember all that, but occasionally you can see that in some book, not book, manual, right? In some manuals or article, maybe. So you know that it is from some of the big salivatory glands. Okay, why we need to know where where the duct exactly connect with the oral cavity. Because if we have sialoadenitis, so we have some concrement, some rock, okay, in the duct or in the salivatory gland, we need to use that point to enter that duct. So that's why we have to know where they're open. Whew. Okay, let it be. Let it be. Parotid gland. Yeah, the biggest one and the most productive, let's say like this gland, right? There is a boundaries. Okay. Represent the largest. Yeah, I said that. Okay, let's move on. Parotid gland. Masseter mandible, no. Okay, it's just anatomy. You remember all that things, I hope. Yeah, see, Stensen's duct for parotid gland. That Stensen's duct is most common in literature, not literature. Yeah, literature. Can we say literature? So it's just some manuals or books or another sources that you can see that. So it's Stensen's duct. you know that it's connected with parotid gland. Okay, so it's arise from the anterior border of the parotid and parallel to the zygomatic arch, right? It runs superficial to the masseter muscle, then turns medially 90 degrees to pierce the buccinator muscle. Not sure how to pronounce that. Buccinator musculus, okay? At the level of the second maxillary molar, where it opens onto the oral cavity. Okay. The parotid gland, parotid gland. Okay, you remember that we have nervus facialis, yeah? So nervus facialis or facial nerve, it's really huge problem for the maxillofacial surgery, because when you're removing the parotid gland, parotid gland, you have to remember about facial nerve and avoid all resections of that nerve, because that nerve is very important for the face and for the mimic muscles. You cannot just cut it. And we have on our YouTube channel, there's a small video about that. If you want, you can watch that. So, but it's just a result of parotid gland elimination. Dissection. No, not dissection. Elimination. Let it be. So it's just removing of parotid gland result. The surgeon shows the branches of facial nerve. Okay. Okay. Parotid gland followed by 5 terminal branches. Okay. Okay. It's just anatomy. Let's move to some physiology. You remember after the physiology course about functions, okay? Not sure that I have to read all that, right? Right, let's move to some clinical manifestation. I want some clinical manifestation. Okay, disorders of minor salivary. Yeah. Actually, you can see that in your practice as a dentist. So those patients could enter your office or cabinet, or how you call that, and say that, okay, I have some small what small piece of something in my lips. Mostly it's lips, okay? So when you traumatized, not you, patient, when patient traumatized the minor salivary gland, it could provoke the inflammation because you traumatized the small dot of that salivary gland. So if you traumatize that, the secret cannot left the gland. Okay, so if secret cannot left the gland, it starts to accumulate there, and that starts to grow. Okay, so we have some kind of cyst. It's not the proper cyst. It's just the inflamed minor salivary gland. Okay, and also it could be result of modassonium glutamate. Yeah, so just have to say that limit yourself when you're eating extra salty and extra tasty food. Extra tasty. Ugh. Okay, that means food with very, very hard taste. I mean the how you call that, the chips, right? The dried potato slices with salt, it's the chips, right? How you call that? Crisps. I know that in
It's a
England,
kist.
how crisps.
Kist.
Okay, I know because in every English-speaking country, they could be different names for that. In the United Kingdom and the USA and Australia use the different words for that. So very tasty, not tasty, very hard taste food. They contained a lot of monosodium glutamate. It's some kind of chemical things that increase the taste of food. That's why you like that. Okay. Okay. So if you overdose that, it could provoke the problems with minor salivary glands. Okay, visible painful swelling, and some resolve spontaneously or require surgery. Yeah, so you can do that in your office too. So you just cut it and that's it. But not just cut it. Okay, you have to extract from the soft tissues with that capsule. So you cut the mucous membrane and then you put the stitches. Okay. Okay, sutures, sorry. Okay. Let's move on. There are minor severe. Rare. Yeah, it's rare, but it's mostly malignant. Not good. Not good, guys. Don't eat much McDonald's food, okay? We have McDonald's in Morocco, right?
Yeah, of course. But
Okay.
it's a
Okay.
rubbish.
It's very popular rubbish. Okay.
Yeah, it
Um,
is.
okay, upper lip, palate, retromolar regions, as always, they're very problematic and rare side are nose. PNS, it means the nose, ear, and the larynx and pharynx. Okay. Okay, Yassine, back to family. Very, very glad to see you, Yassine. Disorder. Okay, we continue. Benign tumors, painless. They always painless. Any benign, maybe. Yeah, benign tumors, they always painless. But still, they grow and they could provoke some problems. If we talk about oral cavity, it could be problems with eating, blooding, and anything else, but not benign tumor itself is problematic. The problem is when that place is starting to traumatize or inflammate it. But benign tumors itself, again, painless. Okay, okay. Let's move to big salivary glands. Sublingual. Problem are rare, minor mucous retention cyst. Plunging ranula. Yeah, ranula is another diagnosis that connected with salivary glands. Is there a retention cyst that tunnels deep? Nearly all tumors are malignant. Plunging ranula. By the way, the ranula as a diagnosis, you can see that in a croc questions. It's very rare question, but still it could be. So ranula could how it created, like it could be raised from retention cyst. So first you have retention cyst and that start growing and you have the ranula, okay, and may arise from submandibular or sublingual salivary gland. Mucus collects around gland and penetrates malleoid muscle to enter neck, and soft painless fluctuant dumbbell-shaped swelling. You remember what is a fluctuation? Fluctuation is some clinical manifestation that shows you that you have some liquid under the skin or mucous membrane. It's when liquid moving under your the patient's skin or mucous membrane, okay? Okay. And surgical excision via maybe via, not sure how to pronounce that, via neck. So we have the neck dissection, and then of course we remove that problem. No problem. No problem. Okay. Okay. Sublingual rare tumors. Of course, most of them malignant. Hope I pronounced that correct. And wide excision, and simultaneous neck dissection. Okay. Simultaneous. Submandibular. Acute sialoadenitis. Finally, we have sialoadenitis, so it's inflammation. Okay. The acute sialoadenitis could be from two reasons. It could be some virus, and it could be, of course, bacterial infection. You can see that mumps diagnosis in pediatric medicine, or when you're gonna be a parent, yeah, your kid could be involved in that problem. It's just viruses. All kids should uh, faire connaissance. How to say that? Should
Sorry?
meet. Yeah, so every kid should meet that virus in childhood. So the more you're less aged, the less problem you will have. So that's why kids should go to garden. How to say that? You know, the place where kids before school. How you
Uh,
call that? It's kindergarten, something like this. Okay, okay. So they have meet that virus, and if organism cannot work with that virus properly, we could have that very problematic disease as mumps. Okay, let's move on. But mumps, uh it's not odontogenic problem. So we do not do nothing with that. We're not removing salivary gland. We just we know that it's infection. So those kids should go to infection section in hospital. Okay. And bacterial infection, of course, could provoke that problem. Chronic sialoadenitis, commonly due to obstruction following stone formation. Stone means concrement or rock or stone, let it be. Okay, submandibular salivary gland, stones. High mucus content, acute painful swelling rapidly precipitated by eating and resolves within 1-2 hours. Why? Because secret collecting in duct, and if you have concrement or stone that obstruct the duct, so the liquid, the secret of salivary gland, cannot move. So that's why it's very painful when you see food or smelling food or starting to eat food. The patient could say you as a complaint, okay, I have pain when I'm eating. And as you can see, it resolves within 1-2 hours. Why? Because that liquid just how to say that? It's eliminating. Okay, okay. I hope you at least understand 10% of what I'm trying to say, okay? It's very hard to explain everything when I'm not English speaking person. Sorry, mi scusa. Okay, tumors. Tumors, very uncommon things, but still, slow growing, painless. Tumors, mostly painless. If you stay with us on fourth year, we're gonna have the oncology of maxillofacial region, and we're gonna talk about all those tumors. Not sure how we should do that actually, because I don't have the experience of conducting practical classes with English speaking students, but still we're gonna do our best, as people say, right? Right. Okay, only 50% are benign. Even malignant tumors can be slow growing. Pain is not a reliable feature. Okay, and we have to do some investigation. Is MRI or computer tomography and file needle aspiration cytology, and no open biopsy. Of course, you're not gonna do that because you're not. But still, you have to know what exactly that problem should be resolved. Management. Okay, small and encased within capsule, intracapsular excision, large benign tumors. They should be excised supraoidly. Okay. Malignant tumors require recombinant neck dissection. It's all about maxillofacial surgery, of course. Dentists do not do that, please. Disorders of parotid glands, common causes of parotoid swelling, mumps, as we know already, acute bacterial sialoadenitis in dehydrated elderly patients, and acute bacterial parotitis and obstructive parotitis causes swelling at meal time, and we know already why. Did you understand me why it's swelling at meal time, right? Students.
Yes.
Okay, Yasin, you're among us. Very nice. Okay, okay. For I understand. I'm very understand that you're not listening well and you have very lot of things to do, but still we have at least pretend that you're students and I have to pretend that I'm teacher. Yeah, it's like a joke, but still. Parotid tumors are most common in pleomorphic adenoma. Low-grade tumors like actinic cell carcinoma are not distinguishable from benign. High-grade tumors grow rapidly, are often painful, and have nodal metastasis. Useful thing is MRI or computer tomography, and FNAC better can be open biopsy. FNAC is these things: fine needle aspiration cytology. Okay. And of course, tumor should be excised. Classification of parotid tumors. They could be adenoma or carcinoma. Adenoma, it could be pleomorphic or monomorphic, and carcinoma could be in low or high grade. There's a few of them, and we're not going to stop on that. So, management, superficial parotidectomy, it's the most common procedure. Not so hard to do, but still remember about facial nerve. Radical parotidectomy is performed for patients clear histological evidence of high-grade malignancy. How we know that? We know that after these things, no open biopsy, and then cytological investigation could set could say if that tumor are benign or malignant. Okay, tumor-like lesions, sialodonosis. It could be the result of few common diseases as diabetes, alcoholism, endocrine disorder, and pregnancy even. Pregnancy is not disorder, sorry, it's not the problem. Pregnancy is a physiological state, okay? Okay, bulimia is psychological things. Okay. Sjogren syndrome. Not sure how to pronounce that actually, because I suppose it's Swedish or Norwegian or something, surname. So not sure how you pronounce that in English speaking places, okay? But just remember about that. Sjogren syndrome, you can meet that in croc too, so you have to at least understand the common things about that. It's autoimmune condition, so it's not odontogenic again. It's just one of the problem that not connecting with teeth, but still you can see that in your cabin, in your office, in your dental. So you have to understand it is a month, or it's a Sjogren syndrome, or it's sialoadenitis, or it's a sialodochitis, or it's just sialosis. Whew, a lot of diagnosis. Okay, okay. And you put your name on that small paper if you send that patient to anywhere. So you have to put some diagnosis. That's why we need to understand at least basic things. Okay, so this syndrome is autoimmune condition causing progressive degeneration of salivary and lacrimal glands. Lacrimal glands, those glands that produce tears. Okay, the oral aspects of primary Sjogren's syndrome consist of mucosal atrophy. You can see it's almost everything. And salivary gland enlargement approximately for 30%. The oral manifestations may include xerostomia. It's when patient complains on dry mucus in oral cavity, right? It calls xerostomia from the ancient Greek xeros. It means dry, and stoma means oral cavity, with or without salivary gland enlargement. So xerostomia, right? Candidiasis and dental caries and taste dysfunction. That all manifestation that your patient could say you if he or she has Sjogren. Maybe it's Sjogren. It should be Sjogren. Um, if you know, let me know. Investigation. Yeah, we could do sialometry, sialography, scintigraphy. It's very interesting investigation actually. Sialochemistry, ultrasonogram, and labial or minor salivary gland biopsy. Management. Okay, symptomatic. From the systemic drug treatment standpoint, immunosuppressive therapy in the form of corticosteroids or cytotoxic drugs have proven effective. In particular, when symptoms are severe. Have to say that that's not we as a dentist or stomatologist who will be prescribed those drugs, okay? Those drugs should be prescribed by immunologist or general medicine, okay? Okay, medicine. Okay, you understand me. Diagnosis and orthopedic treatment of patient with temporomandibular joint pathology, muscle disorders, and articular disorders. Okay, yeah, that could be prevalence of temporomandibular joint dysfunction. So it's all those things that patient will say you as a complaints. But a third of all those patients could have no any sign of complaints. That could be a problem. When you do some prosthetic things, if you're gonna be prosthetic dentist, make sure that you're not over high the bite. Yeah, I hope you're listening. Someone of you at least. Um, so do not over.
Yes, sorry.
Yeah, the bite is very important thing, and the joint and the part of the joint is very important. So if you make wrong danger, you know what is that? It's artificial the prosthesis, okay, that imitate the teeth and gums. So it's danger, right? So if you do wrong danger, you had some not problems. You did a mistake when you measure the high of bite, and you did not you, your dental technician, but dental technician just doing what you have, what you gave him as impression and how patient bite. So it's your problem. It's not the dental technician problem. So he works with the conditions that you gave him. But still, so if you as a doctor did a mistake with that bite, you did too high or mm, too small, you're gonna have, not you, patient, and after patient, you're gonna have some problems with that. But first, with temporomandibular joint and with muscles. So those muscles could provoke a huge pain. The temporomandibular joint could provoke very acute pain. It's all a result of your wrong dentures. Okay, okay. So remember about that. If you want to be or became prosthetic dentist. Ooh, okay. The structure. Okay, you remember all that. It's from anatomy, joint capsule, lateral ligament, submandibular ligament. Yeah, those ligaments are very important too. Diagnostics of tissues diseases. Anamnesis, you know what is that? Symptoms. At the moment, pain, stiffness and tension in the muscles and joints. That's what I'm trying to say. So if you did wrong bite, you're gonna have that problems. You're gonna have that problems, of course, after patient, but patient will come to you with those problems because you made it. So be careful. Impaired mobility of joints, sensitivity. That could be actually even after wrong fillings. If you do some wrong fillings, mostly on molars, mostly molars, if you did wrong, what I mean wrong? Wrong, it means too high or less as a normal high filling. Patient could have that problems with just not dysfunction, but you have first this occlusion, and then you have traumatizing periodontium, sorry, of the tooth, and then you're gonna have impaired mobility. So one joint will adjust for that conditions, you know. That's why, as a result, even with wrong filling, you could have impaired mobility. Huge problem, guys. Huge problem. Welcome to dentistry. You thought that dentistry is a small, fluffy fillings, right? That's it. No, it's very important. Okay, classification. Articular problems. Etiology, oh no, it should be A at the end. Okay, of disc displacement. Disc, it means this thing between bones. Okay, there is a caput mandibular and there is a fossa in cranium, and between there is a wait,
Cartilage.
cartilage. Oh yeah,
Mm.
cartilage disc. Okay, okay. Um, where is this? Not here. Injury of the joint, leading a sharp displacement of the joint head back, loss of incisive path, prosthetics without the principle for freedom and centric. Okay. Yeah, that's a huge problem with joint. Have to say that doctors here, it's a dentist, not dentist, stomatologist in your country. I don't know who doing that, but those doctors who deal with temporomandibular joint is very rare, and uh, and they really learn a lot to manage and treat that joint. So if you find that person in your city, I recommend you keep in contact, because once in a time you're gonna have some problematic patients with those problems, so you can send them to that person, because it's very not everyone who deal with joints. It could be orthopeds, the doctors, right? They deal with temporomandibular joint. It's a very, very complex joint because they move in 3 dimensions, like not
Yeah,
like in cartoons like this,
yeah, yeah.
So it
Also,
moves and it's very, very complex joint. So we have a lot of ligaments. We have a lot of moves of the mandible, and you have to take no, wait. You have to take into account, if you use that phraseology, you have to take into account all those particularities. Two types of displacement of the joint. It's with or without restoration of position. Clinical picture. It means manifestation of the displacement. Clicking when opening and closing the mouth at the same stage. And those patients really will come to your office, and you have to know what you can do or cannot do, or at least to send it to someone who knows what to do. Shift of the
I
lower
think they only
jaws.
need some oil.
Yeah. And as I said, keeping connection. Um, store side after clicking, the lower joints are centered. Okay, pain syndrome is not characteristic. Okay, limitation of the volume of movements is not observed. Okay, deformation of the disc in 31% of cases. Without restoring the position, we have acute and chronic stages. Severe pain with lower jaw movement, with acute stage, of course, a noticeable restriction of mouth opening. There are no noises in the joint, but they can be in the anamnesis. Strain line of deflection of the mandible to the to the sore side, and limiting the moving of the lower jaw in a healthy way. And if that patient lived a long time, it means few months or even years with that problem, taking some pills, some drugs, something, putting cabbage on that place. People are crazy, they do crazy things. Some garlic, cabbage. I don't understand why they're doing that, but still. I'm sure that in your country you have something like this, right?
Yes, you have to be creative in such situations.
Yeah, that's a huge problem actually. So if that problem uh, if the patient had that problem, lot of months, years, that became chronic. So if patient come to you as a chronic or in a chronic stage, it could be no noise, but it can be. See? And of course, when you started asking something, that patient could say, "Ah, okay, oh yeah, I had that half year ago or 3 years ago." That's very important when you're doing something here. I mean, something very serious like danger or some bridge constructions or your frontal teeth restoration, even with veneers. That's very important things because if you, okay, you put veneers, a lot of money, you're great. Okay, you can buy the I don't
Bentley.
know what you can buy the Mustang of yeah you bought the Mustang. Okay, well done. But here problem with bite, problem with everything, problem with muscles, and all your fancy veneers gonna how to say that correctly? Okay, they're
Yeah,
not
vanished.
exist anymore. They not exist
Yeah, they
anymore
vanish. Yeah.
because you did wrong. You did not proper examination. You didn't do all the things that you have to do. So I have to remind you, patient is not teeth. Patient is organism. You have to deal with organism, not just with the teeth.
Yeah.
Whew, is a restriction of opening the mouth with a shift of lower jaw to be to the sore side, sorry, limiting the movement, and it could be deformation in of not two-third cases. No, you're not using that. Okay, let it be 77.
77.
Yeah, I'm just kind of exhausted, sorry.
No problem.
Yeah, you see everything, treatment. Okay, okay, pain relief, diclofenac, ibuprofen, and others. Nimesulide, okay. Sline shape bandage, okay, okay. Is for if for 2 weeks of bandage did not help, it could be two reasons you've seen that. Then surgical plastic surgery of ligaments or removal of the disc are necessary. That bandage you can buy, not you, that the patient can buy in pharmacy or in some pharmacy-like stores, or you can buy, no, you can made it by yourself. We use that um, Um, okay, let's say another way. In the first semester of fourth year, you're gonna have the cycle of oral surgery that causes traumas, I mean injuries of maxillofacial region. And we talk about a lot of things there. We talk about the the fractures, the soft tissues wounds, and all that things. And we talk about bandage, of course. And when a student was here, was sorry, were here. When students were here, we did that bandage with sorry, I don't know that word with okay, it's just bandage. Hmm. Okay, you have the same name for all those things, for bandage and for bandage. It's the same word in English. Okay, so that thing that you use to overroll your anything, okay?
Yeah.
And bandage is the upper, it's construction. So construction and the material had the same name. I don't know how to distinguish that. In English, I mean, because in Ukrainian, it's different names for that.
Okay.
Okay, so students did that on each other, of course. And you can say to your patient to do that in a home, of course. I mean, we still talk about the treatment of disc dislocation. Whew. And of course, first reason, first point, first line in treatment of problems with temporomandibular joint is limitation of the function. Not open mouth wide. Do not eat not strong. The hard, not hard food. The hard consistency food. Okay, so do not do any all that things. So and then non-steroid drugs and bandage. That's it. That's all that joint needs. That's more than enough. And if not, you know that it's surgery. Okay, classification in children and adolescents. Sweet. Yeah.
Sorry, but with the joint,
Yep.
it doesn't need any exercise or something to make it like flexible or.
Yeah. We talk about inflamed temporomandibular joint. If it is inflamed by trauma or bacteria or other things, first you have to limit that to take that inflammation go to just anti-inflammation therapy. And when you will reconvalescent the
Yes.
when patient will be healthy,
Yeah.
after that, in few weeks after your treatment, yes, you have to do some exercise to normalize the function of temporomandibular, but not in first days, because
No,
it's very painful
no, of course. Yeah.
after a few weeks of treatment,
Yeah.
and not very hard moves, just like slowly exercises, some massage, how you
Massage.
pronounce it? Yeah, massage of that regions and other things. And also there's some drugs for external drugs for that. I recommend you to use, I don't know that word. It's a snake. Wiper. Do you know what's a wiper?
No, actually.
It's a kind of snake. Okay, so you use the poison of snake. Not you. You can buy it at pharmacy. You don't have to
Yeah, of
catch the
course.
snakes.
I'm not gonna hand his snakes.
We're not gonna be a Harry Potter things,
And
okay? So it's ointment. You know what is that?
sorry, what?
Ointment.
No.
Wait. Ointment. Yeah, it's ointment. You don't know that word?
No, sorry.
No. Okay. Where's your pharmacy? Where is your pharmacy? It's a pommade en français. Do you know what is that?
C'est quoi en français?
Pommade.
Ah, la pommade. Ok, ok, ok.
I'm gonna find some Arabic name for that. Marham. You know that now?
No, actually, because there is some words that we keep in the original language.
Okay, I'm gonna put that word here in. Maybe you recognize it. Maybe I pronounce it not well here. Can you read that?
Murahim. Oh, yeah.
So it's that some things that you could put on the skin.
Yes. C'est comme la pommade.
Oh yeah, c'est pommade. Okay, so you use that externally with the snake poison or Also, we have at pharmacy, I'm not sure about your country, we have in pharmacy the okay, the extract of bees. You know what's a bees? It's like
Yeah,
small
yeah, yeah, yeah.
insects that
That
create
product,
honey.
honey. Yeah.
Yeah, so it's an ointment with bee extract. You can use wiper or bees for that. You
Okay.
don't have to catch bees on the street. Yeah,
Okay.
you can buy. That's funny, really.
Yeah.
You,
Imagine it.
you can buy at pharmacy though, so you can use that externally. But first, you have to limit your function, and then after reconvalesation, if that word exists, uh,
T- telling the patient to wait for you while
yeah.
you're in the garden
Yeah, that's
following the
very
bees.
funny. Yeah, recovery. Of course, I knew that one. So after recovery, you start to those massage, some exercise, all that things, and and that's gonna be more than enough. If not, it's only surgery gonna help you. Any questions?
No, I think
No,
everything
it's
was
the end of our meeting this year. Wish you the best of luck. We're
thank
not
you.
gonna meet again,
Let's hope so.
malheureusement.
Let's hope
Yeah,
so.
but I wish you the enthusiasm in your education process,
Thank you very
because
much.
without enthusiasm, it's very sad to be a student.
Yes,
Best
yes.
of luck and hope that we will meet in fourth year if you pass the croc. So force yourself to
I
open
hope so.
croc questions and do your best.
Yeah, thank you very much.
No problem. We'll
Have a nice
see.
day
Bye
too.
bye.
Do pobacenia.
Do побачення.